before we get into it, and I will tend to avoid the I word because it doesn't sit comfortably with me, but we'll talk about it in other ways. I was struck by something that Raquel had said yesterday, which then came up, which was the idea of methodologies and how the methodology drives the ideas and so on. And there's this, the person looking in the light where they're looking for something.
The mic is not projecting.
The person looking under the light because that's what they have, or another analogy would be the idea of if you've got a hammer, everything looks like a nail. And yet I read a Sufi similar 12th century Sufi story, which was of the person who was in another person's house looking for his key because the light was there. But it wasn't about looking in the wrong place, it was about trying to adopt other cultures. It was about looking in other people's houses for information. And I think what Pascale and I are going to try and do is bring together different approaches to research and talk about how different approaches to research can shed light on a single question.
So this is very much about the methodology bit, and we're doing this from the perspective of recognizing that there's also a lot of PhD students in the room who would like to learn from this. So the image that is projected there is actually, I don't know, those of you who have been to Ghana, this is one of the quite common carvings that you'll find. It's called Unity, but to me I think it can be used in a whole range of ways of thinking about the research that we do. Essentially, the challenge for the carvers is to carve out this piece with a single piece of wood. There is no cut, there is no join, it is a block. And technically it's about life, and it's about the importance of life and the fact that we are all connected together. And so from the way that we talk about this is that given this complex connectivity, how do we then pull apart each individual bit in a way that makes sense for the purposes of research, to reduce it for the purposes of research, but at the same time still see it as part of a whole. And this is what the research approach is that we try to adopt. So we'll talk first a little bit about conceptualizing research in this area for us, which means, given the complexity, how do we reduce and then rebuild? Because it is, I think there is often we often, and I think this has come up several times, that there is a tendency to reduce for the purposes of research, which is important, but at the same time we always need to recognize that we're doing it as part of a greater whole. Exploring health in context, we thought this particular research example would be useful because it's generically about the notion of health, so that it's applicable across a whole range of areas. And critically for us as well is the fact that we are ultimately, while we're researchers, we're also public health practitioners. So this has to be going somewhere. It's not just about feeding the silverfish. It is really about, so given our understanding, what can we actually do? Because I am sorry, we are not going to change people's attitudes overnight. But we do need to do something to address inequities in our society. How can we pull out the information that we get from this sort of research to actually begin to see what the ways forward might be? A focus very much on the different methods that we use, and then some sense of how we might analyze and use this data.
If you have been part of any MPH program in North America, you will have had the Titanic example as a way of looking at social disadvantage across a population. And the reason for that is that when the Titanic went down in 1912, we can now look at who it is that died and who it is that survived. And we know that Kate Winslet survived, and we know that Leonardo DiCaprio died. And what is it about those two people that should result in the male in steerage and the female upper class person surviving and so on? So it in fact provides a very nice way of looking at the interactions between, in this instance, it's going to be class, as in class of steerage, and gender, but there's also age data in there as well, but I don't look at the age data. But, so RMS Titanic, 1912, launched the unsinkable ship, luxury liner, and it sank in the North Atlantic when it struck an iceberg. If you look if you look at different parts of the vessel, you see very different lives lived. So this is a picture of the bowels of the ship where they're sort of feeding the coal fires, messy, cramped, unpleasant, and you could go up into the first class and you'll see absolute luxury. This was where the Astors were on the vessel. It's real wealth. This is the probabilities of survival. This, you can't see the numbers. Okay, females, males died. Males died at a far higher rate than females. About 60% of females on the Titanic survived, and about 25% of males on the Titanic survived. So there's immediately a huge gender gap. And if you just wanted to look at the gender issues, and you weren't interested in the intersections, in the interactions between the two factors, what you would see is that for some reason, men were dying and women were surviving. Why was that? Why is it that in a world in which men have all the power, the men are dying and the women are surviving? Because this seems incredibly unfair to me. Or you could look at it by class, and if you look at it by class, this is first class. First class passengers survive. This is second class, this is third class, and this is crew. And the crew do fairly badly, but the crew were important for getting people off the ship. And then if you move to the interaction, you get, and I didn't choose pink and blue, this was just chosen by the software, but it happens to be pink female, blue male, first class, second class, third class, and this is crew. What's interesting is that you get a clear gradient here in terms of females and class. First class women survive better than second class women, better than third class women, but female crew survive very, very well. Female crew do as well as second class and almost as well as first class. So you get a really nice interaction on gender and class. And males, you see first class males, they don't survive anywhere near as well as the females, but they survive much better than second class. The third class and the crew are sort of somewhat similar. So this is more a blancmange set down here that's sort of the same, but they're not doing as well as the first class passengers. Why is it that men died at such a high rate on the Titanic? Why is it? Chivalry. What a ridiculous idea, and yet one of these very cultural ideas. Oh, a deeply cultural idea that women and children first. I will be on the boat, I can tell you. I'm sorry, Pascale. So there are interesting cultural artifacts there, but then if you actually look at the way the vessel is constructed, there are interesting structural factors as well, because third-class quarters were cramped, much more cramped than the second-class quarters, so the passages were narrower, it was harder to get out, you would get stuck. In first class, you're on the top level, they're luxury, you've got wide expanse. So there's an interesting relationship between both the structural factors of the way things are built around class and the actual attitudinal things, the cultural factors around class. So for us, or for me, I hear intersectionality and I look at this and I say, oh, so we're talking about an interaction effect. What an epidemiologist would say was an interaction effect. Build that into the analysis, look at it. The difficulty for the epidemiologist, I think, is then trying to work out what it means. Yes, I saw the interaction effect, but then you have to think about the cultural artifacts and you have to think about the structural artifacts in order to make sense of it.
Okay, so this then goes back to having a sense of what the problem is. And I think in some ways it relates a little bit to what Leslie said as well, that you have to have a sense of, some sense of a starting point about where you're going, to be able to then break it down. Because if you think about the PhD students, for instance, having to do their confirmation of candidature or whatever the process is, they may talk about a question that sounds really important and so on, but what they need to demonstrate is how it is they are going to research it in an effective and rigorous way. So they have to deconstruct label, identify the specific variables that they're going to be addressing, even if it's not necessarily necessarily breaking it down and seeing it as a siloed thing. So generally, when we're looking at this sort of research, what we're looking at are internal states, things like attitudes and so on, external states, which are our characteristics, behaviors of what people do, artifacts, the physical, and also the environment. And the work that we do is very, very much also about the interaction of the environment. A little bit now, but not so much about climate change, but I do acknowledge whoever the climate change person is, that is an important thing. But it is, all of these things are important, and I think in the social sciences we tend to forget the environment and the structure of it and focus more on the internal states. So we will, the whole example of the specific research is focused around the notion of health, which is we thought was a generic one that everybody gets, and everybody has a sense of what health is supposed to be. This would be a photograph of a classically, looks a happy 18-month-old girl. She in fact has quite severe kwashiorkor, so if you look clearly, she's got all the signs of being diseased, but looking happy and therefore looking healthy. So we have different ways of conceptualizing this thing that, again, between the body and the environment, the notion of what illness is and so on, can and capture a whole range of different things. So this is generally what we would think of as health. But the reason that we started looking at this general health thing in the first place was, again, for the purposes of the PhD students, understanding the notion of the DALY, the Disability Adjusted Life Year.
I don't know how many of you know the DALY. The DALY is a measurement of population health at a global level that is supposed to be disaggregatable down to lower levels. The genesis was some work done by Chris Murray and Alan Lopez in 1991 with the World Bank, and it then led into the 1993 World Bank report on development. The reason they were interested in it to begin with was that there was a strong focus, when looking at global health, there was a strong focus on mortality, and specifically around child mortality. And they were concerned about the focus on both those when you're talking about people of all ages and at different levels of health. And so the non-fatal health outcomes, the morbidity rarely played any role in how one measured a population's health. Often you would see mortality rates, age-adjusted mortality rates, but you wouldn't see anything about the morbidity. And it's very difficult to combine the morbidity and the mortality into a single metric. No standard unit of measure. So the goals of the DALY in trying to develop this new measure was to disentangle epidemiology from advocacy, because a lot of the advocacy occurred because you didn't have a good metric of population health, so people would assert where their health was. You know, we're in desperate need, you ought to give more resources to us, but it wasn't wasn't on the back of any solid evidence. So they wanted some objectivity, and they wanted some independent assessment of the burden of disease. They wanted to include non-fatal health outcomes, and it was to develop a common metric so that you could in fact do comparisons across countries and across disease. And now you can look at the rankings, and it's like, oh, and the burden of disease tables, heart disease is the highest, and then you've got something else, and then you've got something else, and they're rank ordered. Central to the DALY was this notion of a severity weight. So I don't know if you have kids, whether your kids play this game, but my daughter loves playing it, and she's now 19, and she still plays this horrible game, which is, would you rather be blind or would you rather be deaf, Dad? You know, would you rather have no legs or would you rather have no arms? What is the severity of a particular condition? How disabling is that condition? And we particularly focused on this because this is important in terms of how the metric works, that one understands how disabling a particular condition is and what it contributes to the DALY. So each non-fatal health outcome had some severity weight, some sense of how awful is this condition for health. And specifically, it ignores context. It didn't matter if you were blind in Delhi, or you were blind in Canberra in Australia, or you were blind in London. Blindness carried a certain severity. And therefore, we could aggregate this information across all the blind people across the world, and we could look at what blindness contributed. And it used a particular measure of disability associated with the International Classification of Disabilities. In the way they phrased it, and this was back pre-2005, and it shifted a bit, but it still makes sense to talk about it. When they needed people to think about how disabling a condition is. So I want you to think about paraplegia. How disabling is paraplegia? But I wanted you to think about the average individual. And I want you to think about the average individual with the condition, taking into account the average social response or milieu of the world. So do you have that in mind? Have you figured out what the average person with paraplegia is in the average place in the world?
I'm wondering how the WHO did that.
Well, it was they did do it, and it was Chris Murray's group that did it. And you have to have this capacity to be able to think about this thing. And we had done some critiques of this approach, and the response was this sense of an intrinsic, I say intrinsic man, and please throw rocks at me later.
You couldn't actually find a photograph of an intrinsic woman, otherwise it would have been an intrinsic woman up there.
Critically, for the DALI to work, the health has to lie within the skin. It has to be intrinsic to the person. We can't talk about it lying outside the skin in any way, shape, or form. So you have to have this intrinsic person. Health as a function. And when thinking about, say, mobility, this is the way we need you to think about it. Because you need to know what the average context is for the average person in the average world. We need you to think about the ability to walk 100 meters on a level, well-lit surface that isn't slippery, and that when I ask you about how awful this disability is, you need to think about the disability in this context. So if, for example, I have a moderate limp, and I live in a world that is a well-lit, flat surface that's non-slip, that's one thing. And if I live with my moderate limp in Kathmandu post-earthquake, that's a different thing. But you're not allowed to think about that. You're not allowed to think about what the health might be like in that condition, because health is intrinsic to the person, and it has to be considered in the average milieu. So we just need to think about the average person on a non-slip surface that's well lit. That's Murray 2002. We found this incredibly hard to work with, because it didn't make sense to us, because it basically says that health is something that doesn't interact with the world. And for us, it was something that interacted with the world. You have to operate in the world, and therefore you have to understand it in the world. One of the ways they looked at this intrinsic sense was to use what's called the person trade-off, where it's sort of, if you've got so many people of this kind of disease, how many would equal that without any disease, and you have to sort of work out some trade-off midpoint. What's interesting about the trade-off in the way they worked out the severity weights is that they said, well, we had, in fact, they don't do the person trade-off anymore, but when we had groups, we had these two groups that did the person trade-off for a condition, and we could look at the correlation between the two groups. And lo and behold, there's a high correlation. And there's a very high correlation because the endpoints are very clear. Everyone agrees that dead is dead, so they're down here. And everyone agrees that perfect health is perfect health, and they're up here. So that's anchored. You've already anchored the endpoints of your distribution. And now what you need to do is you need to haggle about those conditions in the middle. And the condition, this is a hangnail down here. We all agree that a small hangnail on your finger doesn't contribute much to burden of disease. We all agree that being in I got them the wrong way around. We all agree that being in a coma is really not a particularly functional state. But where is deafness? And these groups and deafness will lie in here, and this is where you're going to get the maximum variation in terms of how people evaluate it. Because it's too hard actually to evaluate it on a non-slip surface in a well-lit room, and that's the average social milieu.
So we actually got funding from the Global Forum for Health Research to do this, because we did actually want to take on and challenge the underlying assumption within the DALI. So the research question, therefore, was how do real social, cultural, and environmental contexts affect the impact of a health condition. Is the intrinsic man right? Is that the right way to do it? And in a sense, the relevance to this is that this is the essential intersectionality type question, that we are looking at interactions of real life to people's real life, right? So we did what we posed was a question, a comparative study between Cameroon in Africa and Australia. The sampling inclusion criteria, again, this goes back again to the PhD stuff. You really do need to think exactly what you want to be able to do with the research afterwards, so conceptualize it really clearly. So we chose, the inclusion criteria were men and women between the ages of 25 and 35. We picked two conditions. We picked epilepsy and we picked paraplegia, both of which were at the time quite middling sort of conditions within the global severity weight exercises that Chris Murray's group was doing. We looked at the different communities, so in terms of the environment. So with epilepsy in particular, are we doing both epilepsy and paraplegia?
We'll need to talk about both. Anyway.
Okay, so the two conditions were epilepsy and paraplegia. This is the criteria for epilepsy. They were living in the community. We looked at the frequency of the frequency of the seizures and whether or not they were on medication. So these were the specific variables that we looked for in both countries. For people with paraplegia, we looked at 25 to 35-year-olds, people who had their injury within the last 2 years, and also living within the community.
Sorry, can I just duck
Yeah.
in? We started with an interest in looking at deafness, and it turned out that basically you couldn't, because if you looked at deafness in Australia was relatively easy, but if you looked at deafness and we were interested in congenital deafness, if you looked at deafness in Cameroon, so you looked at someone who had been deaf from birth, so they had no language, and there was no functional signing within Cameroon, and most of them had serious mental health issues by the time we would be able to interact with them. So deafness, they weren't even on the same planet in terms of what these conditions meant for deafness in Australia and deafness in Cameroon. So we couldn't even begin to, that was like finding your finding before you've even started. We just couldn't even work that way. Even when it came to the other conditions, so with epilepsy, we said they had to be on medication, but the classes of anti-epileptic medications are broad, and some of the modern anti-epileptics leave you very functional, and some of the carbamazepine leaves you feeling like you've been sort of had cotton wool stuffed into your head. So yes, you're functional, but you can be a bit woolly. Even with the paraplegia, working out what paraplegia was, because you get the diagnostics for paraplegia in Australia, but in Cameroon you didn't necessarily get a diagnostic for paraplegia, but you did get a diagnostic for loss of lower limbs, and often it turned out after we had done this that most of the people were polio victims.
The other interesting thing about trying to get the sample in Cameroon is that, and I've actually seen a paper recently, that for paraplegia in a lot of lower income countries, your life expectancy reduces to something like 2 to 5 years post-injury, because people get septicemia in the bed sores and septicemia with their wounds, and that is just not the case if you have paraplegia in Canada or the UK or anywhere like that has a facility that has the external facilities to be able to deal with it. So stated very specifically, and I pulled these out again with recognizing that we have PhD students in the room. Objectives, really useful exercise to do. Be very clear what your objectives are and write out your design or your methods that will specifically address the objectives. So to examine the notion that the burden of disease is broadly similar without regard to country, environment, gender, or socioeconomic status. A cross-country comparison, multiple method, quantitative measure. We had quantitative measures of health status. We had qualitative assessments of health status and clinical histories. And the second objective, to develop detailed descriptions of the experience of the burden of disease as they related to these specific contextual factors. And for that was largely qualitative. So we had in-depth interviews, we used photo voice, and we did in-depth interviews following the photo voice exercise as well. I'll come to it. So these in more detail. So we took the clinical histories. We used the SF12, which is a health status measurement tool, the ComQual, which is a comprehensive
it's a subjective well-being, quality of life measure.
And then the in-depth interviews, and specifically the categories that we were looking at were things like rurality, gender, socioeconomic status, and so on. The photo voice methodology, so a lot of, as I said, and you would remember that I called myself a whore of methods on Monday or Tuesday or whenever it was. So the photo voice at the time, and somebody mentioned that she was using photo voice as well. My sense is that in doing qualitative research, particularly when you're trying to work phenomenologically, where you're trying to get a sense of a real in-depth, getting into people's households, that sort of thing, that it is really difficult to be able to conceptualize the questions that you want people to answer. And you also create a power relationship in a sense, because people are only going to tell you what you ask them. So when we, in a study like this, where we really wanted to have a sense of what their lived experiences were, but at the same time we wanted it reasonably circumscribed across the specific parameters that we were looking at. It's used, photo voice is used very much as a sort of participatory action research tool. We used it here specifically as a way of getting data, of getting people to generate the data that they wanted to give us. It involves giving people cameras, and at the time, as you can see, I don't think you even see these things anymore, the disposable cameras. So we gave them cameras, and we just gave them a very broad brief. We explained to them that we are interested, so for example, given you're a woman in this community with epilepsy, we would like you to give us the sense of what life is like for you, and we would like you to think specifically at what you think what your life is like as a woman with this condition compared to a man with the same condition, or with a woman without the condition. We would like you to think about what your life is like as a woman within this socioeconomic status, with this condition, and so on, as opposed to somebody who lives in the city, you living in the rural area. So we just explained to them the things that we wanted, and just left the cameras with them. And then came back afterwards, gave them some time, came back afterwards, developed the films, because at the time you didn't have electronic gizmos, so we had to actually go and print out the photographs. Told them to pick out, it was a 36 exposure camera, told them to pick out 6 of their best photographs, and then we interviewed them on the basis of those photographs. So sat with them and said, okay, why did you take this particular photograph? What does this tell? What does this photograph mean to you? And interviewed them on the basis of that. Now, there's several other methods that in terms of really getting that sort of interaction from participants. So at the moment, we're working on a study, for instance, where we now have smartphones. So we are asking community members, and this is a slightly different, obviously different agenda, but we're training people in the community to make documentary films, short clips. So and there are apps available that actually show you how to, a total novice, how to make a short documentary film. And it is about them identifying what they think the health priorities are in the community from their own perspective, for instance. There's another, those of you who listen to Radio 4, there's a really, one of the programs that I really enjoy is called Desert Island Discs, for instance, where the person is told, the person you're interviewing is told that you're going to be marooned on a desert island. What 6 songs, what 3 songs, whatever, would you choose to take with you, and people tend to choose songs along their age, along, you know, something that they remember from their childhood, something that they remember from when they were teenagers in uni, something that they remember when they got married, you know, their favorite song when they get married, and so on. But what that gives you is a really powerful way and it's a half-hour program, of getting real insights into the person's life and their relationships and so on, in a way that if you just constructed an interview schedule and you were asking people questions, you just wouldn't get. So it's really, and I constantly listen for different ways of trying to engage people to get real in-depth insights into them. And people are happy to talk about themselves. Give them the attention, and the difficulty is trying to get them to shut up like me. So let me move on. So photo voice, does that generally give you some idea of what it's about? So they were asked to select 6 of the developed photographs, and these photographs were then used as prompts for the second set of in-depth interviews. Lots of practice, lots of playing. This isn't actually from that particular field site. This is another project. So the results. I think we've got the conference first.
So I'll talk briefly about the quantitative data. There were not huge numbers of people involved. The black columns are the Australian data, and the grey columns are the Cameroon data. And this would be paraplegia. And what you see with the paraplegia is that the modal response is very poor health for paraplegics in Cameroon, and the modal response is very good, not excellent, but very good for paraplegics in Australia. Now, you'd be familiar with Sen's work, where he looked at self-identified morbidity in India, where people in Bihar rated themselves as better than people in Kerala. If you look at the Australian data, you'll find that Aboriginal Australians, who have horrendous health outcomes, rate themselves as having better health than white Australians, who have very good health outcomes. These people knew where they were on the ladder. The interesting thing, what is surprising about the Australian data in some ways is how well they rated their health, but it is known that people with paraplegia accommodate over time and their quality of life improves, and certainly their subjective sense of their lives and their well-being improves. But at the time, the Paralympics it was just prior to the Paralympics in Australia, and being paraplegic was not a problem just prior to the Paralympics in Australia. And in fact, we were told of one case where a person had gone to a doctor to seek the doctor to remove his foot, because unless he was missing a foot, he wasn't able to play in these games. So it was in fact seen as, for this person, it was seen as a desirable commodity to be disabled, which is, to my mind, perverse, but this person saw it as appropriate. This is a plank crossing a river. So, and it's in a rural village in Cameroon.
This is one of the photographs. So we'll show you a series of photographs, all of which were taken by the participants.
And this is taken by a participant, plank crossing a river in the Cameroon. Just that there. It's not their photography skills. We'll go back and train them. One of the things we found challenging, we thought that the photo voice would provide photographs that were data in and of themselves, and then the interviews would be additional. And some of the photographs, we just look at the photograph and go, why did you take that photograph? So I remember this photograph very well, because I looked at that and went, bridge across stream, paraplegia, wrong. This came from someone with epilepsy. And it came from someone with epilepsy because culturally, within the area in which the epilepsy occurred, epileptics, people with epilepsy, were not allowed to cross water. So they weren't. If you were a fisherman and you had epilepsy, you lost your livelihood. It was culturally inappropriate for a person with epilepsy to cross water. So this person was locked in their village, not because they couldn't cross the bridge, but because they were culturally not allowed to cross the bridge.
Sorry, just a little bit more detail on that. It's not just that culturally they were not allowed to, but the traditional explanation for epilepsy was that there was the gods that live within the river would be offended if somebody with that sort of condition went across. So in order to make sure that the village was in harmony, they weren't allowed to go across and anger the gods, which meant essentially that they were isolated. There's no way that they were going to go, once you have started, you've had your first seizure, you're no longer allowed to cross over to go into town, to the market, and so on.
This was from a woman with epilepsy, with paraplegia. Her, again in a rural village. I think this one's rural, this one's urban. And she said, I used to engage in petty trading. I have not got the courage to go out and battle with people. This is because of the problems which I have. You should know that when I want to urinate, I cannot retain it for more than 5 minutes, maybe 3. I have to put on something to retain the urine, but that means I smell, so better I stay home. So just that simple problem of loss of bladder control, and you're locked in your house. And you have to fight if you're getting out. So you lose your livelihood, you lose your capacity to get out the door, not because of necessarily something about the mobility, but because of the loss of the bladder function. And this was one of the photographs taken by someone with paraplegia in one of the villages. And if you can imagine someone with paraplegia in Australia, you will have a wheelchair. It will function beautifully in that well-lit environment across the flat floor that doesn't slip. Or you can live here. And the advantage of living here is it doesn't matter if you have a wheelchair or not, because it won't work even if you do have it. And if you look at the disability weights, the way the disability weights were constructed, they assumed basic support in terms of things like a wheelchair. Bad luck, no wheelchair. One of the interesting things that came up was this problem, and this is a well-known problem in UNICEF, which is the problem of the child carer of the person with a disability. So you end up locking up 2 lives, not just one. And this is the child carer who's moving the person around. But also you can see just the kind of surface over which they're working. This is the more typical kind of wheelchair that was available, and it's sort of the hand-driven rather than rolled. And again, it possibly coped better with the environment, but even so, the environment is not brilliant for wheelchairs.
As opposed to in Australia, where you have the taxis, you can call specifically for a taxi that will help you to cope with it. This second one, and we've only used one photograph, but was brought up by both people with paraplegia and people with epilepsy. There was sorry, let me just check it. No, I didn't. So the one of the women with epilepsy had a photograph of a bus and a photograph of her child's wheelchair. Stroller. With the child's with a label, name and address on it, and the idea there was that if she had a seizure while she was with the child, at least and people around would know how to look after, who to call to look after the child. But also there was which you don't see properly. There's at the time on the buses there's a hook for wheelchairs and strollers and things like that. So again, it was about the fact that the council, she was talking about the council and the bus services being helpful about trying to accommodate them. In fact, it's moved along quite a bit now. So the steps go all right the way down, so you can go on with your wheelchair and so on. This is an example, and we had surprisingly large numbers of toilets, photographs out of the Cameroon data, and this is just an example of a typical outdoor toilet for those in the wealthier rural household, because at least it was off, and it's just a room you go into, and there's a little hole dug in the middle there.
And it gives, I think one of the important things about that is it gives some sense of why the septicemia would be important, because you get the pressure sores from just sitting, and then you have to drag yourself through shit, and you get septicemia.
So this, it takes me about 5 minutes to get to the toilet. I take the wheelchair until I get there, and then crawl until I'm close enough, and then I lie down on my back and adjust my buttocks until my anus is facing directly in the hole, and then I can use the toilet. And this is another example again of a toilet, and there had been the person who took this photograph was explaining that the logs had rotted and he had fallen through on one of the occasions, so he had to call to be pulled out of it. So it is, I mean, you look at this and you just think, this is not rocket science to say that the condition is the same across different environments. That context does not matter. That all these factors that we talk about do not have relevance to public health and the way in which we need to see and deal with public health problems. Another example, in this room I do everything. It's kitchen, bedroom, sitting room, and toilet. Because I have no control, they made a hole in the middle of the bed. Most of you know what the cholera beds look like. In the middle of the bed, so when I'm lying down or sitting up in the bed, it passes through into a pot under the bed. Because the room now smells, nobody comes to see me. And this was a woman with paraplegia. An example of another toilet, as opposed to the Australian stories where the paraplegia was about celebration of ability to do things in spite of the loss of function of the lower limbs. Shiny new wheelchair that he got because there was a whole lot of resources that were then made available for paraplegics at the time. And we juxtapose this as an example of different kitchens. In Australia, if you sustain the injury as a result of you slip in a public place or whatever, the state is obligated to build a house for you that takes account of your disability. So the kitchen, everything is made, is custom built to be able to take account of the disability.
And what you can see there is that the woman can actually see into the pot. She can sit in her wheelchair and she can look into the pot. Whereas in Cameroon, the woman is away from the stove. It's incredibly dangerous, and the sort of the waving and the hope.
Another example. So this young lady has epilepsy. And she actually posed for this photograph. She is not, as a woman, she is not allowed to cook. She's not allowed near food, but the issue is burns, because within the rural communities, they still cook over open fires and so on. It's just not something that is allowed. So she talked about this. She took these photographs, but talked about it as the fact that she is now nobody in her community because of this condition, and it doesn't matter whether it's controlled or not. Once she has been labeled as having epilepsy, that is it for the rest of her life. So it's all of these things combined.
And between this photo and the previous photo where you see the woman stretching across, you can also see the very clear SES differences in just functionally what's available.
Another photograph that was taken by, this one was taken by an Australian with epilepsy, and he had taken it because that was his goal. So if he had managed to stay on his drugs and was able to go a certain period without having a seizure, what he wanted to do was to go rock climbing. So the nature of the stories, even though the brief was the same, were very different across the two countries. Same thing, he had taken a photograph of somebody sailing, so he was really trying to get into some of the extreme sports. Same sort of thing here. So in terms of the analysis of the data, do you want to talk about the concept first and maybe address it? It's just an example of different interactions.
So we were interested in what the interactions were going to be between the sort of the wealth and outcomes for Cameroon or Australia, what the gender differences were going to be for Cameroon and Australia. So it was very much bound up in the contextual effects. We just have drawn it out in terms of a sort of a little difference over two environments, a broad difference over two environments. One environment being better off than another environment, and interaction effects between them. And in some ways, the interaction effects were the most interesting ones.
It's just an illustration, for instance, of then when you're analyzing the data, there are quite a few data packages now. I tend to use NVivo just because that's what the university license has. But it is actually possible in doing the analysis to be able to draw out, on the basis of the broad themes that we started off with, then pulling together all the transcripts that you, all the information that you get, and then doing a further analysis on the basis of that to be able to see where the intersectionalities occurred. And I'm a little bit uncomfortable using the word as well, because that's not the word that I used to use. But essentially that's what we had. But it also, again, because of the way the qualitative packages work now, you can pull them together to look at the commonalities, you can look at the differences as well that occur across those different themes in different places. So there's some quite powerful analyses that you can do now on the basis of the packages that are available as well. So essentially one of our main messages out of that was the question of whether we measure what we value or we value what we measure. And I think it's an important framework to have in terms of public health and conceptualizing our questions. And in some ways, going back to your issue of what is the specific methodology, that it is. Don't take the tool and decide that on the basis of this tool I'm going to do this, but decide what it is we're interested in, and then find the best tool that you can that will give you that measurement.
I think one of the most interesting things for research, for academics, is when students come and they say, I want to look at this and I want to do it I want to use qualitative data. It's like, that's a lousy way of doing that. You should use quantitative data for that. Or they come and they say, I want to do a survey. It's like, why would you want to do a survey for that? And it really is how you go about measuring it and what the appropriate method is for a particular question. But if all you know, if all you have is one tool, you will apply that vigorously to everything. So you end up valuing those things because that's what you know.
This is just a very quick example that I wanted to talk about under the interesting, innovative ways. As I say, I really get excited about what different data mean, what constitutes the whole idea of what constitutes evidence or not. And this is an example of, I was doing some work with refugees and asylum seekers in Australia, and there was this relates a little bit on I think it was raised, a point that was raised in the last discussion about whether we're interested, where there's power differentials in getting the views of the oppressed as well as the oppressor. So Australia has gone through periods of liking and not liking migrants and refugees and so on. Yeah. Well, it depends if you're white. So yes. So there was a period in the early 2000s when there were a whole lot of Afghan refugees that were needed to be taken in through the legal means into Australia, and the way the Australian government, the policy was that they would be immediately relocated into the rural areas, and there were literally rows in a lot of the country towns about not wanting migrants in their food chain because the skill of a lot of the particular group that was going into this town was that a lot of them were butchers, so they were going to be given jobs in the abattoirs, and the community didn't like this. So what the mayor did, bless him, was he said to avoid riots in his town, he put out a notebook in the town hall, and he said rather than fights breaking out in the street and so on, if anybody had a problem with the Afghan refugees coming into the town, they should come into the town and write out specifically what their objection was. And we obtained that data and did an analysis of it. And that, to my mind, and I will argue till I'm blue in the face, that constitutes real data because it is about evidence from the community about what can be done, if anything can be done, about the nature of the problem, and it is very much a view that is expressed in terms of the power from the people who were doing the discriminating against the refugee community. I just threw that in as an example, more to just throw in that we need to be creative about looking about the sources, looking for the sources of evidence. These are the second last slide, I think. We decided to talk about the notion of intersectionality of methods as well. That very often we talk about, even in schools of public health, we talk in very tokenistic ways about multidisciplinary research, interdisciplinary research, and so on. When we were working in the UK, I think one of the things that I found really surprising was that they talked a lot about multidisciplinary research, but what you ended up with was, you put in a grant application with people from a whole range of different disciplines, you get the funding and then distribute the money to the different people. They go off and do the work from their perspective, and that was it, without a sense that there was collectively some way of addressing the particular problem, actually bringing together the evidence and getting people to think outside the box of their comfort zones about the methods, and also about the results that are found, and ways in which those results could be synthesized in a real way to make a contribution for public health. So there's a whole range of across it's very clear when you look at work of multidisciplinary versus interdisciplinary teams, the sort of output that you get, where people are actually thinking together from the starting point of a particular problem.
In part, I can't remember the order of things in terms of where we've done it, but we had produced a theoretical piece, which was He Hath the French Past, Social Stigma, Social Value and Social Exclusion. And it was titled He Hath the French Pox because I had been looking at causes for libel under UK law, and there was a case in the late 1800s where someone had asserted that another person had the French pox, syphilis, and that was seen as a case for libel. And the judge had said that what was important about it was that by asserting that someone had this disease, you essentially excluded them from society. So we were interested in this process of excluding from society and how you do that. I think in terms of the intersectionality, in terms of the interactions across classes or groups, what was interesting is that we had done work where we'd looked at different groups of people and the kinds of exclusions that would occur. So I have done some work on HIV-related stigma. We didn't ask people who had HIV about their stigma. There had been an enormous amount of work done on that. We were in fact interested in other people's views about HIV stigma, because there's a lot in the literature on HIV stigma. And essentially there were three factors that were stigmatizing. One was that you had HIV. One was that you were an IDU, you were an injecting drug user, or you were a sex worker, or you were gay, or you were one of the men who had sex with men. So we actually constructed vignettes where we asked people to look at how close a social relationship they would be prepared to have with people who were injecting drug users. People who were injecting drug users who were also MSM. People who are sex workers. People who are sex workers who are also IDUs. And what you see is a layering of the stigma. It isn't that it's not purely additive. You don't get, there's this much stigma associated with HIV, and then there's this much associated with IDU, and then there's this much associated with being a commercial sex worker. They layer on top of each other, and in some cases you in fact get a sort of a bounce effect, so it's worse. If you're an IDU and a sex worker, it's much worse, but if you're an IDU and an MSM, it might not be. And again, it depends very much on the social context you're in. In Thailand, there was some greater understanding for some of the kinds of layerings than there were in other places. And it's a social valuation. It's around how your culture interprets these things and the need to exclude these kinds of people. Moral pollution is a serious offence in some places, and moral pollution makes not quite so much sense in other places. So the French Pox paper sort of tried to look at how we go about bringing together mechanisms to exclude people across gender, ethnicity, disease category, and how that might work. And we came up, I think what was interesting about the paper in some ways was that we came up with arguments for how you could predict the exclusion. You know, if you do this and you do this and you do this, you will really destroy a person. So, for example, if you're interested in destroying the livelihoods of refugees, the first thing you need to do is you need to claim that they're illegal. Because everyone knows that illegal people are bad people, and you wouldn't want to share your society with an illegal person. And then, if they actually come into your country, the next thing you want to do is you want to make sure that they can't get a job. Because if they can't work, they have no economic status, and then they're useless to you as well. And it kind of proved the first point that they were criminals. And you can systematically construct the exclusion of different people, and it becomes an interesting way to look at the layering of it and how to go about constructing the exclusion of people. But it's very much from that, not from the position of those who are excluded, but from the position of those who are doing the excluding, and how you might go about constructing it to do it really well.
And in some ways it addresses the discussion again that we had earlier on about the processes and not just the individual categories of people. That there are processes, and in some ways it is those that we have some control over in terms of thinking about ways of addressing them. And this is the last slide, which is the intersectionality of the researchers, our two beautiful children.
Yes.
That's not to say those doing intersectionality don't have children together. Thank you.